Yeah. Hi, Dr. Priscilla.
Hi, Suresh. Sorry.
Yeah, so we start in another minute or so. I think Dr. Kamlesh Tiwari also joined today. I just checked. Tiwari sir, you joined? Usually you join at right time, but I just checked.
Hi.
1 second. I'll just check. Yeah. Yes, doctor.
No. This is recording on YouTube, it says. So I just wanted to, yeah.
Okay, I'm not aware of that.
Yeah,
Usually
this
they
says,
say only for,
yeah. So
oh, they got a link in YouTube also.
Yeah.
Okay.
We'll have to delink that.
They told only in Zoom, but I'm not sure because 2 meetings we conducted so far. But it's not shown in any other YouTube channel so far. I'm not aware of this one going in YouTube so far.
It says recording on YouTube. So.
Oh, recording on YouTube. Where are they showing?
On the top right hand, can you see that?
I'm going through my iPad, so I'll just check. Sorry, once again. Okay. So you don't want to?
Yeah, I would prefer it not to be on the YouTube, please.
Can the organizing team can we stop sharing the YouTube?
Yeah, if you can just stop recording on YouTube, I will share a PDF and I will share the chapter. So if you can just actually take that off, please.
I'll stop sharing the 1 second. Yeah. Yeah.
Maybe this 3 dots life sciences, whoever they are the ones who are recording it on YouTube.
Come again. Sorry, what is the question? I'm not able to hear.
No, I said the 3 dots life sciences, the people who are conducting the program seem to be recording it on YouTube. So
what we can do now there? I'm not aware, sorry, really, because the last 2 meetings, nobody's asked about this one. And I also checked there is no YouTube link is going on there. So I thought only Zoom because it's organized by AP and ICP. Anybody from the IT team has joined now? IT support, if anybody is available right now? On Dr. Priscilla right now because the IT is not responding.
Sure. Who's this three dots life science
What do you want?
profile?
3 dot license is the organizer there. He's the IT support provider.
Okay, they're the ones who are recording it actually.
The 3 dot, can we stop recording this one for this sessions? Anybody from the 3 dot? Can we stop recording this one? One second, I just check with the person. Dr. Priscilla, they stopped recording. That's what they told. So can you start sharing? I just spoke to the 3 dot there. They said they stopped sharing. They stopped recording it.
Okay, yeah, because the YouTube icon is still coming up on top. So anyway.
But I just spoke to him that he said he stopped recording. That's what he told me.
Okay. Sure. Will the PG present the case first?
I just checked the what happened. He's like having some issues in joining. But I'll start introducing the thing just in the meantime, like I'll let him stop sharing it.
Yeah. I mean, I can start
Okay,
if you
okay. I'll check when he, 1 second, I just. So I think Dr. Kamalesh Shivari usually joined today. I think he's not joined. So thank you for accepting our invitations in a short notice, despite your busy schedule and despite your not being well. But fine, thanks for accepting our invitations in short notice. In fact, this session was supposed to conducted by Dr. Tanu for antibiotic principles. So, but she was stuck with another 2 presentations. She's not sure when it's going to over. That's why the preponement happened. But despite a short notice and despite a busy schedule, accepting the invitation is that we sincerely thank from APA as well as ICP chapter. So today the speaker is Dr. Priscilla Rupali. Everybody knows it. She does not want any introductions. She is a professor and head of infectious diseases at Christian Medical College, Vellore, and popular speaker. And she is authority on the FUO, and she has wrote a chapter of FUO in APA textbook also. So people might definitely know about Dr. Priscilla. So without further things, the introduction part right now, I thought my PG will present the case, but he has got some issues in joining with the link. So I think at the end of presentations, after the end of Q&A, we just think time is allowing. I asked my PG to present the case. Otherwise, we'll start with the presentations. Dr. Priscilla, you can start sharing your slides and start presenting. Stage is yours.
Sure. Thank you, Suresh, and it's a pleasure to be here. So this is something that I have been interested in PO for a long time. And a lot of the work that we have done with regard to this is actually found in the API textbook. And I will send you a link. I'll send a link to Dr. Suresh after this meeting is over. However, I would like to ask people not to record because we use the same, there are copyright issues with the CMC program that we run as well. So this is basic principles and approach to pyrexia of unknown origin. And so I'd like to just take a minute or two for the outline of what my talk is going to be. One is to talk about the evolution of the definitions, a case-based approach to the diagnosis and management, some of the India data that is available, and what are the possible algorithms. So whenever we're talking about fever, I think people have various definitions of fever, and you often have people coming to the outpatient and talking about, how they've had fever for many years and how they have fever twice a month. And so there are various definitions that various complaints that patients actually come to you with. But if you ask them to clearly document a temperature, you will find it does not really meet the criteria for fever. So fever in FUO, the mean oral temperature is about 36.7 plus or minus 0.4 with low levels at 6 a.m. and high levels at 4 to 6 p.m. So this is kind of normal. So everybody normally itself notes a slight increase in the diurnal variation of temperature. So when you look at the definition of fever in the morning as well as the evening, there is a difference of almost 0.8 degrees centigrade. But when you look at, most FUO studies, they don't clearly define a temperature, but studies which have used a clear-cut definition have used temperatures definitely more than 38 degrees centigrade, so definitely more than 100.4 degree Fahrenheit. But definitions can range from 100.4 to 101.3 degree Fahrenheit. So when we talk about FUO, we're talking about a duration of 3 weeks with minimum diagnostic testing that is required before calling it an FUO. We also need to remember there are certain times or certain category of population which actually have lower body temperatures like older age and low BMI. So when evaluating fevers, ensure that the fever has to be physician documented or consistent documentation by the patient. And there's no subjective feeling of warmth or flushes that you often find in postmenopausal women. And the normal range of temperature should vary from 97 to 99. So these are the normal temperature values, and they're different from axillary, oral, and rectal. So this is the first definition of FUO, which is fever of unknown origin, report on 100 cases. And you can see this is the first one that was present in the journal Medicine in the year 1969. And so this was talking about fever of unexplained origin, a report on 100 cases. And at that point in time, there was only classic FUO that was there. So this is what they had used. This is a picture of Peter Stoff and Beeson, illness of more than 3 weeks duration, fever greater than 38 degrees centigrade on several occasions, and cause uncertain after 1 week of in-hospital investigation. So these are the various definitions: classic, nosocomial, neutropenic, and HIV-associated FUO. So there are many causes of fever now, and each time we're thinking about fever, we know that there are a variety of causes, and often we have to take clinical calls on deciding what is more likely to be the cause of fever. Now, there have been various revised criteria by Durack and Street et al., but they've never been validated, no clear scientific evidence. But it definitely just kind of reflected an improvement in diagnostic techniques. And this time period of 3 days was really based on modern culture techniques revealing a diagnosis or skin tests or imaging, etc. So we also have complex ICU patients for whom there may be not just one cause of fever, but fever may be multifactorial. So it may be the brain injury that is producing, he may have catheters inside, he may have broad spectrum antibiotics, he may have had some surgery. And you will find there are a lot of things that will tell you what could go wrong. So they could have decubitus ulcers, there may be a cutaneous rash that appears, the labs may show leukocytosis, intermittent pyuria, etc., etc. So you have to really think about what it is. So classic FUO really is the most oft described condition, and is usually community acquired, where you basically take any fever from the community which has been there for 3 weeks without a diagnosis. And this is in spite of, even if they've been admitted for 1 week and you don't have a clear-cut diagnosis. When you're talking about nosocomial fever for at least 3 days with negative preliminary cultures in a hospitalized patient, so they should not have been incubating the infection at the time of admission. Then you're talking about immunocompromised FUO, which is unexplained fever in an immunocompromised individual, talking about neutropenia, immunosuppressive drugs, primary immunodeficiencies, and a use of 10 milligram prednisolone or equivalent for more than 2 weeks. Human immunodeficiency virus infection, especially when the CD4 count is lower, and biological therapy. So there are a variety of causes for causing an immunocompromised individual. In addition, we also have a travel associated FUO now, and this is a new entity again that has been introduced. So if you remember earlier, it used to be neutropenic FUO and HIV-associated FUO, but now it's actually changed and merged into immunocompromised and the travel-associated FUO. Now, travel-associated FUO is a traveler who's had an unexplained febrile illness, probably acquired in the country he's visited, and the cause may often be unfamiliar to the physicians in the home country. So these are the causes of fever in FUO, and they have changed year after year, and you will see the no diagnosis part of it keeps on increasing. Now, there have been various studies that have been done in the country, and quite a few of them have used a variety of definitions. And you can see here when you're looking at different parts of the country, your infections still predominate, closely followed by malignancies and collagen vascular diseases, and quite a few of them still remain undiagnosed. So when you look at what are the infections that could be producing it, and again, you will see there'll be differences, but overall, you will find TB actually is pretty common. There are times when people have talked about typhoid being one of the causes, but that's basically because they use a different definition of FUO. Typhoid, as you know, will be classified under acute febrile illness rather than as a pyrexia of unknown origin. Okay, so although the proportion is similar across various studies of infections, the spectrum may vary from area to area, and there is varying levels of stringency with definitions. So there are various differences in the studies. They're probably due to true regional differences as well as partially due to availability of lab support and referral bias. So this is an older article from API Textbook of Medicine. And here you will see they compared the causes of infections across the world. And again, you will see here infections in India predominated, closely followed by neoplasms. But this is not what we see elsewhere in the world. And if you take United States and Europe, you will find that infections are equally at blame to malignancies and to connective tissue disorders, etc. So this is an article which is in the Journal of Association of Physicians of India, so JAPI. And please have a look at it. This is a etiology of classic fever of unknown origin among immunocompetent Indian adults. This is a study that was done in our center. And you can see here, we had very stringent definitions of what we classified as PUO. And here you can see tuberculosis, melioidosis, infective endocarditis, visceral abscesses, and histoplasmosis predominated as the top 5 differential diagnoses of a classic FUO. And most of them did need some amount of invasive techniques to actually come to a diagnosis. So it was not something that was easily available. We had to do something like, bone marrow aspiration or a lymph node biopsy or a diagnostic splenectomy. So often invasive techniques were used to make a diagnosis. Now, when you look at neoplasms, you can see here non-Hodgkin's lymphoma predominated, followed by Hodgkin's. And among the non-infectious inflammatory diseases, SLE and vasculitis seem to have the maximum causes with regard to classic FUOs. So just to divide it into the big 3 and the little 3, and this is an older definition, where again, we just talk about the big 3 right now, but the minor 3 that we need to think about is just a habitual hypothermia, which some people may have, but really it does not really affect them in any way. So they have a baseline body temperature that is slightly higher, but of course that will not accompanied by any kind of systemic symptoms, either weight loss or any other things. Factitious fever, this is again something that we can probably come across. People who, say that they have fever, but actually they're manufacturing, either they, do something to the thermometer or, they record themselves a higher temperature, even if they don't have it. And of course, drug fever, which we don't give enough importance to. So prolonged fever really is tricky, and there's often multi-system involvement. They have non-infectious mimics. Generally, by the time they come to you, they've already had a trial of antibiotics, anti-TB treatment, and a thorough history examination will yield clues. And the most important thing is, even if you don't make a diagnosis today, you will definitely make a diagnosis in 1 week's time, because any disease that you are unable to diagnose is in constant evolution. So it's important to not rush in with some kind of a treatment, because then that will actually hinder you from getting to the actual diagnosis. So lots of causes. I've just put in some infections over there, but like we mentioned earlier, FUO can be tricky, and it's important for us to make a clinical diagnosis based on the information that is available to you before rushing in with some kind of a treatment. So most of them do not suffer from unusual diseases. They have atypical manifestations of common illness. And generally, all you need is to just think a little bit as to what is the likely cause of this and what are the possibilities that you could actually consider. Lots of history that we forget to ask, which may be important. So immune status, medications, travels, immunization, exposure to pets, arthropod, bites, cardiac anomalies, prosthetics, and some comorbid conditions, any previous visits to the hospital, and domestic and international terrorist activity. So examination-wise, if you examine thoroughly, the skin can be one area which will give you clues, provided you actually do a thorough examination. So hidden areas are usually behind the ear, axillary, breast, and groin folds, and per rectal examination, genitalia examination, neck rigidity, all of these are pretty important. Now, before you actually think of a PUO, it's important to rule out an ordinary cause of fever, which could be localized, but you just may not detect it because the patient may not complain of it. So total and differential count, malarial parasites, urine microscopy, chest X-ray, typhoid, blood cultures, then depending on the syndrome, LFT, CSF, ultrasound of the abdomen, CT scan of the brain, all of these may be dictated by the clinical picture that you have. Lots of other useful tests, maybe things like CRP, so acute phase reactants, LDH, a CPK, a HIV test, which we may not often think about doing. And, either a PET scan or a CT abdomen thorax. Generally, the more invasive tests that we used to do in the past, like an exploratory laparotomy, has more or less been replaced by the imaging techniques that we have today. Febrile serologies may be useful, blood cultures may be useful, and microarray can be useful for detecting the various bacteria, viruses, parasites, etc. Autoimmune workup, colonoscopy, arteriography, radionuclide scans, PET scan, and a biopsy of the liver and the bone marrow. So I don't know if any of you have heard of this man. This man is called Sutton. He is a bank robber, and he used to go around robbing banks, and people used to ask him, so why are you robbing banks? So he said that's where the money is. So what implication does it have on a PUO workup? So Sutton's law is what we call as a law for investigation in PUOs. So look where the money is and do not carry out a battery of routine examinations in a conventional sequence. So now this fancy term of Sutton's law is now replaced by potential diagnostic clues or PDC. So if you look at diagnostic approach of FUO, you need a directed investigation, and you'd use a staged approach. You can either use a PET scan for a total body inflammation scintigraphy. You can do therapeutic trials, or you can do a wait-and-see strategy. So when you're looking at common causes of classic FUOs, the infections usually are intra-abdominal abscesses, endocarditis, osteomyelitis, extrapulmonary TB, complicated UTIs, and prolonged mononucleosis syndromes. These are often the causes of infections. Non-infectious causes may be things like sarcoidosis, Still's disease, SLE, and then, of course, malignancies like lymphomas or hypernephromas. It's important to also not ignore sinusitis, cholangitis, dental abscesses, or prostatitis as well. These are the other causes of FUO. So drug fever, pulmonary embolism, factitious fever, hyper IgD, Muckle-Wells syndrome. All these are other important causes of FUO. So I'll just talk about some cases as we evaluate them in the terms of the various categories of fever. Can I ask the people who are online to kindly mute themselves? You are disturbing the proceedings, so please mute yourself while you're
Please
listening.
mute the.
So this is a 25-year-old student from Bihar who presented with a high-grade fever. It was a moderate to high-grade fever. He had red eyes, blocked nose, anosmia. He had dry eyes and mouth for greater than 6 months. Oral ulcers had resolved 1 week prior, and he also had non-pruritic evanescent flat lesions below the legs. And he had also had some arthritis. He had significant loss of weight and appetite. He'd been started on some anti-TB based on.
Please mute all the participants. Please mute all the participants.
He'd been started on some TB treatment based on a history of FUO with some improvement. There was no high-risk sexual behavior. He was a non-smoker, non-alcoholic, and he had no other history suggestive of a collagen vascular disease. So these are some of his lesions. Now, anybody wants to share in the chat as to what they think it could be? So you could share in the chat as to what you think your likely diagnosis is. So these are some of the lesions. You can see the arthritis here. You can see some of these lesions which are evanescent. You can see here, some ulcers. Okay, so we've had various diagnoses: Wegener, sarcoid, endocarditis, Kala-Azar, okay, Lyme's. Okay, all right. So let's look at what we think it could be. So on examination, he was emaciated, febrile. He had conjunctival suffusion. He had pale and edematous fingers, like I showed you. He also had a hepatosplenomegaly and an arthritis. So if you summarize, he was a young boy, low-grade fever with skin lesions, dry eyes, dry mouth, anosmia, arthritis, and a polyneuropathy. Okay, so we have various people talking about Sjogren's. Good diagnosis. I would have thought so too. So these are the things that we thought about: SLE, overlap syndromes, tuberculosis, heavy metal poisoning, leishmania, etc. So these are the tests, and you can see most of them are okay except for a mild anemia. He had a CRP elevation. He had a C-ANCA elevation about 28.9, and the bone marrow aspiratory find was normal. Ultrasound showed a hepatomegaly. Now, he had these various lesions, so we call dermatology, and really they first looked at him and they said, oh, he's actually got a Hansen's disease, and this is a type 2 lepra reaction. So all we did was the skin smears, and you can see the skin smears are full of these globi of acid-fast bacilli. So this was actually a type 2 repla reaction of Hansen's disease with multibacillary leprosy, and all the features actually fit into it beautifully. So he was started on multibacillary drug treatment, and he improved quite well. So I've talked about this just now, but just to say that, again, various studies have shown the same kind of percentages for infections and malignancies and collagen vascular diseases, and often all of them mimic each other. So it's very important for us to take that into consideration. This is from the API textbook of medicine, and you can see here this is a classic FUO algorithm. So you do a complete history and exam, you exclude drug, fever, and stop unnecessary drugs. And these are the specific clinical findings: lymph node abscesses, eschar, skin lesions, etc. If you don't have findings, LFT, blood cultures, ultrasound of the abdomen, bone marrow trophine, and aspirate, and they can be various inflammatory markers like CRP, ASR, etc. So they can be a positive or negative findings, and depending on whether that's positive, you can do an appropriate follow-up and diagnostic testing. The negative, then you can go on to do further tests, possibly serologies, imagings, colonoscopies, etc. Coming quickly to nosocomial FUOs, and the nosocomial FUOs basically involve a compromised host, microorganisms in the hospital environment, and a chain of transmission. All of that actually contributes to a nosocomial infection. So prevalence is 4% at any hospital, and 25% of them usually are because of a device-associated infection. There can be an underlying susceptibility and potential complications of hospitalization, but always begin a search at the original surgical or the procedural field. And usually more than 50% of them are infected. So there can be various causes which we all look at when we're evaluating a patient. It can be an IV phlebitis, prosthesis, sinusitis, prostatic abscess, DVT, pulmonary embolism, drug fever, etc. So the evaluation needs to be systematic, and if a patient is sick, after appropriate cultures, you can start antibiotic therapy for a possible source. And if hemodynamically stable, initial workup should include blood cultures of antibiotics for at least 72 hours, chest X-ray, a urine microscopy, etc. Sometimes all you need to do is really stop all drugs and think of a C. diff infection. So this is another gentleman who had multiple burns, and he had a prolonged hospital stay, persistent fever, multiple debridement, and he was colonized with multiple gram-negative organisms. And he was actually treated with carbapenems to promote epithelialization. So he basically had a CR, Pseudomonas aeruginosa. And this was a while ago when we didn't have, various options that we have available now. And you can see here, he actually ended up finally with a blood culture showing a pan-resistant Pseudomonas, had a vegetation. He was started on colistin, but of course he developed multi-organ dysfunction, shock, and he eventually died. So this is the evaluation of nosocomial fever. So if you always have to look for localizing symptoms and signs. If they're positive, you targeted treatment. If they're negative, you review the invasive devices. Check if it is central line associated bloodstream infection, VAP or COTI, and always think of hidden sites. So candidemia, metastatic abscesses, endocarditis, etc. If it's negative, you actually continue treatment as appropriate. Always look for the original procedural field, so post-surgical collections, hematomas, and complications. Neutropenic FUO. So oral here again, the definition everybody really knows. Basically, fever, duration of 3 days without a diagnosis, and a patient who has severe neutropenia. So ANC less than 500 or expected to decline to less than 500, and usually secondary to myelosuppressive diseases or cancer chemotherapy. So these are the various predisposing factors to a neutropenic fever: degree of neutropenia, a rapid decline in the neutrophil count, prolonged duration, some immunological impairment of the host, whether because of the cancer or the underlying immunosuppressives, disruption of the skin and the mucosal barriers, cancer not in remission, comorbid illnesses, and virulence of the pathogen. These can be the possible sites of infection, bloodstream to GI tract, to the skin, the respiratory tract, etc. And so just quickly, another case is a 15-year-old boy with a B-cell ALL. He was on salvage chemotherapy. Febrile neutropenia was ongoing. He was on posaconazole prophylaxis. His fever preceded the disease, and he has had periods of prolonged and profound neutropenia. His disease was not actually in remission, and his exam as such was within normal limits. But soon after, when he went into neutropenia, you can see the swelling on the right side of the face, blood cultures, imaging, everything was non-contributory. We were called in for a consult, and we found that he had a fusarium sinusitis. We started him on treatment, but he had a bad disease, and though palliation was planned, a DNR plan was instituted, and he expired a week later. So there can be various causes which can suddenly develop, and especially in neutropenic FUO, the features become much more prominent when you have recovery of neutropenia. So that can be something that we have to actually consider whenever we're dealing with a neutropenic FUO. Sometimes with the recovery of neutropenia, the original diagnosis may become clearer. So multiple blood cultures is key: urine cultures, chest X-ray, ultrasound of the abdomen. So basically imaging, which will tell you that you could focus your investigations there. And you can use anti-pseudomonal antibiotics. Always start with that. But of course, proceed with investigations to ensure that you're on the right track, and that will help you. Wait for the blood cultures to come back in 24 to 48 hours, search for another source of infection. And if you can't find, then of course, go ahead with imaging, etc. Usually fungal cultures, fungal assays need to be done on the 5th or the 7th day. It's likely to be bacterial rather than fungal in the first few days. But if the neutrophil count doesn't recover, fever continues, you're quite okay to go ahead on the 5th or the 7th day to think in terms of either empirical antifungal therapy or go in for investigations. Now, nowadays, nobody really goes in for empiric antifungal therapy. Almost all of us would do a galactomannan or a HRCT as such. And if you find that the neutrophil count is actually recovered, initially you may have a slight worsening of the fever, but you just have to hang on. And usually with the recovery of neutropenia, the fever also actually goes away. HIV-associated FUO, and usually it's an infection in 90% of the cases. Again, it depends on your CD4 count and the burden of that particular organism in the environment that the patient is likely to encounter. The lower your CD4 count, the likely you're to be exposed to specific diseases, and we are all aware of what it could be. Now, when you look at prolonged fever in HIV, again, you can see TB is actually the most common, followed by Cryptococcus, then PCP, community-acquired pneumonias, and liver abscesses, toxo, histo, etc. So this is a gentleman from Meghalaya who had coughed for 3 months, no fever. He had a skin lesion over the chin, oral lesions, and pain on swallowing, and he was seropositive for HIV. His pulse, his hemodynamics was stable. He just had a hepatosplenomegaly, and you can see his chest X-ray had shown this. Now, anybody wants to suggest what it could possibly be? So this is actually a necrotizing pneumonia. You can see this is an inhomogeneous opacity. You can see that there is some necrosis here, possibly going on to developing a lung abscess here. Okay, so he had a CT scan, and here more clearly you can see the lobar consolidation with necrosis, and it had cavitation involving the posterior segment of the right upper lobe, and a thick wall cavity in the right upper lobe, and a few low density nodules in the lung. He also had lymph nodes, and he had a mild pleural effusion as well. So what do you think are the various differential diagnoses here? So people, if you want to suggest it in the chat, people have said NTM, PCP, okay. Yes, but you have a skin lesion. So let's summarize. It could be he has a necrotizing pneumonia, he's HIV infected, and I haven't really told you his CD4 count, but he has a necrotizing pneumonia with a skin lesion. Any ideas? So TB, yes, since I already put TB there. Anything else that you'd like to suggest? So histo, yeah, a lot of people have said histo. Some people have said staph. Good thought. TB, of course. Histoplasma. Okay. All right, let's deal with it. So atypical mycobacteria is also something that we considered, especially Mycobacterium avium intracellulare complex. Now, one very important thing to consider apart from the usual bacterial, which can cause necrotizing pneumonias, are actually nocardias. So nocardiosis can produce a skin and a lung lesion, especially in an HIV-infected individual. So always keep that in mind whenever you're evaluating for a necrotizing pneumonia. Among the fungi, histoplasmosis, cryptococcosis, etc. So we did a lot of other tests. You can see here a lot of things were done. Bronchoalveolar lavage was negative, but we did a biopsy of the ulcer, and that actually showed penicillium and FEI. So you can see how, there's a red pigment that is diffusing into the agar there, and that usually indicates, and you can see this fluffy fungus that has actually grown. And, if you were to see it on histopathology, you will find that they actually have a transverse septum there, which is dividing into the two. That basically happens because this fungus does not bud, it divides by binary fission. Okay, very common in Southeast Asia, Thailand, Myanmar, Vietnam, etc. And usually it's called penicillium. Now it has changed to Talaromyces, but you can see it should be named because it looks like a pencil at the end of it. So usually you need invasive techniques to make a diagnosis. Very often they present similarly to the case that I just presented to you. And median CD4 count in the series that has been described is around 20. So treatment is again amphotericin B followed by itraconazole, and you need to continue the itraconazole till the CD4 count crosses 200 in all these individuals. Death is rare, but can occur, especially if you don't pick it up early. And people can die of, either disseminated penicilliosis with involvement of the GI tract. So we've lost patients when they've bled or they've actually had relapses, etc. So when you're talking about people living with HIV, you really have to divide them into antiretroviral naive plus those on heart. Now, if you are antiretroviral naive, cough and breathlessness, you basically do a chest X-ray, do an oxygen saturation. You can do, gene experts. And if they're positive, of course, you know what to do. If they're negative, then, of course, think in terms of imaging, which will help you to localize. You have a headache, altered sensorium, always think in terms of TB or cryptococcus, like we mentioned earlier. Those are the two most common causes of FUO. So obviously brain imaging, CSF analysis, and cryptococcal antigen. If it's negative, then you can actually go on to doing a multiplex CSF PCR, further brain imaging, which can localize maybe an MRI scan, and of course a JC virus PCR also, which can produce this. Now, there are times when you basically don't have localizing signs or symptoms. An ultrasound may be positive. If the ultrasound shows you nodes, you try and get a tissue diagnosis, either nodes or liver or spleen, and you treat appropriately. Bone marrow aspiration and trephine, generally, unless there is a pancytopenia, it's often difficult to get a diagnosis just plain bone marrow aspiration alone. If the patient is on heart, it depends on whether it is less than 6 weeks or more than 6 weeks of fever. Less than 6 weeks after start of heart usually indicates either an iris or a drug fever. Okay, so nowadays the drugs that we use, of course, do not produce fever, but the earlier nevirapine, efavirenz, all of them did actually produce quite a bit of drug fever. If it's more than 6 weeks, then think in terms of a pathogen that causes a late iris, and that can be either TB, it can be CMV, especially when your CD4 count is really, really low. If they're positive, treat appropriately. Negative, you work up as a classic FUO, even if they're HIV infected. So really, the most important thing to remember is that the effective diagnostician is the one who makes least mistakes in dealing with common conditions, not the one who makes occasional brilliant guesses. So brilliant guesses are all very well, but it's very important to go methodically and systematically to get to a diagnosis. So I think tips: extensive history, repeated physical exams, do intelligent and invasive investigations, identify potential diagnostic clues and go there. Avoid empiric shotgun therapy, because the moment you start antibiotics or anti-TB treatment, you really will not be able to think further. So it's very important to establish a diagnosis for a PU. Most importantly, stewardship perspectives, empiric antibiotics are not indicated in a pyrexia of unknown origin, unless, of course, you're clear and there are features suggesting, like, for example, a culture-negative endocarditis. You have other clues which tell you that it could be an endocarditis. So a plausible, so even if you are thinking of giving antibiotics, make sure you know what the diagnosis is. So you've committed to a diagnosis of endocarditis and are giving antibiotics so that you know what to do when your patient doesn't respond. Very often, just rushing in and giving antibiotics without a clear-cut diagnosis means also that you're really not thinking of what it could possibly be and how you could actually go wrong. Before starting antibiotics, always send different kinds of cultures, because that is likely to be the one which is likely to be having good diagnostic yield. So I'll stop with this. These are the various causes of FUO. This is the article. So JAPI 2019 is freely available for download, and it actually has a very good article on the causes of FUO that have been determined. So pyrexia of unknown origin is often a perplexing and a challenging problem. They can be infectious and non-infectious causes of fever. The risk stratification of the host is essential to determine etiology. TB is the most common cause of FUO. and different geographic areas predisposed to certain diseases. Nosocomial and HIV-related infections are often infectious, and neutropenic fevers are often challenging, but diagnosis is made on the recovery of neutropenia. So I'll stop with this, and I'm happy to share any questions if there are any.
Thank you, Dr. Rupali, for wonderful presentations. I think you have covered, because previous speakers so far in the last two sessions, they didn't put any cases. So that's why we keep some cases for the discussions. But fortunately, I've shown 4 cases for today's discussion. I think we can have a couple of minutes, because 15 more minutes. We'll discuss some of the questions raised by the audience, and some of the questions before the session itself we obtained from the participants right now. So the first question posted in the group: common etiological agents for fever. In your experience, what are all the common etiological agents you came across? You have shown your data, but still people want to know. Can you pinpoint 3 common infectious causes and 3 non-infectious causes in your practice?
So I think the common infections that I come across is still actually extrapulmonary tuberculosis. That's the most important cause of FUOs. After that, of course, we see melioidosis, especially chronic granulomatous melioidosis, as a hidden cause. Very often it's a bone source, or it's a deep-seated visceral abscess, which can actually be a cause. Often fungal infections, difficult to diagnose, like penicillium and histoplasmosis. It can just be like, for example, a gastrointestinal ulcer. They may have features of, they may have an interstitial pneumonia. They may have other things going on, but often it's very difficult to pinpoint anything. Now it is easier now, because we also have a histoplasma urinary antigen, so it's easier. But TB, melioidosis, histoplasmosis, infective endocarditis, these are the top 4 differential diagnoses for an infection. Among the causes of non-infectious inflammatory diseases that are there, the most often what we encounter is actually Still's disease. Still's disease closely followed by either SLE or a vasculitis. So SLE, usually in younger males, that seems to be very difficult to pick up, and people often miss it. So young male SLEs, and then, of course, a vasculitis, especially in a person who's in the 3rd or the 4th decade. So these are the common causes we encounter. Among the malignancies, like I put up the data, actually non-Hodgkin's lymphoma is a very common cause for us in our setting. All the other malignancies, I must say, are surprisingly rare. And among the other things that we often tend to miss is actually thyroiditis. Thyroiditis can be a very important cause of fever, which is difficult to diagnose unless you actually think about it.
Thank you. I'll ask my PG Dr. Pugal to share, because you have given a couple of interesting differential diagnosis or common causes of FEO. Pugal, if you quickly show your slides. Before that, I'll ask you start sharing your slides. I'll ask a question to Dr. Rupali again there. One of the interesting questions come recently now. We also see, ma'am, can you show which bank I need to rob? So what are the things I need to go and see? That's the question he's asking you there. So where do you want to rob? Where is the money he's asking?
So, I mean, see, very often all you really need to do is sit down with your patient, take a good history. There may be something that is like, for example, in the patient who had the penicilliosis, the giveaway there was that he was a farmer. Second, that he was actually from Manipur. So those are like potential diagnostic clues which would tell that is where the money is. So automatically you know from the geographical history that it is likely to be a penicillium. Okay. In the patient who actually had the type 2 lepra reaction, if you remember, he actually had a lot of these skin lesions. He had a lot of trophic changes. I don't know if you noticed in his feet. His feet looked very shiny. There was no hair. And those were the kind of clues which could point you in the right direction. So that's really where the money is. And if we had picked that up, generally you could have picked up leprosy as well.
Okay. I'll just show you the questions. One more question asked in the group. Fever.
I'm sorry, I don't think I can hear
Priscilla,
you.
can you able to hear me?
No, not really, actually. I don't know if others are able to hear, whether it's my internet or yours. I'm not sure. Sorry, so I'll just look at the questions in the chat. I'm somehow not able to. So I think there was a question
Can you
about
hear
drug
me?
fever. So there's a question about drug fever. Let me answer
Yeah,
that.
that's what, drug fever.
Okay. So answering about drug fever, there are a variety of drugs which can actually produce fever. And the first thing you do is take a list of the drugs and have a look at them. So the common culprits are usually things like Bactrim, things like phenytoin, carbamazepine, sodium valproate, people with multiple myeloma, thalidomide, lenalidomide, all of them can actually produce fever. So any drug that you feel is not absolutely necessary, that's the first thing that should be done, is actually the drug should actually be taken off. Then I also see a question about novel biomarkers for PUO. Okay, so novel biomarkers for PUO, unfortunately, there are various biomarkers developed for individual diseases, but there is no biomarker which is overall evaluating PUO. Now, when you're looking at, like a high sensitive CRP, for example, it tells you that there is something going on and that you probably need to investigate further. But that should always be, you're not treating a high CRP. Often you have to actually look at the patient. And I've had a lot of patients coming to me saying that, look, I don't have fever, but I have a high CRP. So I would strongly caution against just looking at, a biomarker to make your diagnosis. They have to support your diagnosis, but cannot be the only reason you investigate a patient. Your fever has to definitely be there and it has to be documented. Role of immunomodulators.
One more question regarding, you told about the empirical treatment.
Yes.
Empirical treatment says there is no empirical treatment according to you. One of the questions.
Yeah. So, you should shy away from empiric treatment because otherwise it will never tell you what the true diagnosis is. And you have to try your best to actually come to a diagnosis. So, role of immunomodulators in PU, when I do go ahead and give immunomodulators, I've actually made a diagnosis of either Still's disease or a male SLE or a vasculitis. Generally, I do not start unless I at least have a clinical diagnosis, leave alone a confirmatory. So I don't usually do that.
Regarding empirical ATT, when you consider empirical ATT in your practice?
So I would, like, for example, we've actually, while that study was being done, which also was done by one of my postgraduates, actually, Dr. Devyani, who's now a neurologist. So when we did that thesis, we actually told patients, look, we don't have a diagnosis right now. You have two choices. One, we could be completely wrong and we could start you on TB treatment. Second, you could just wait and possibly come back 6 weeks or 4 weeks down the line. And at that point in time, your disease would have involved and it will be easier to make a diagnosis. So sometimes you may find that the clinical picture suggests. So there may be lymph nodes, there may be a fever, there may be an evening rise, there may be a cavity, but you're not able to get a microbiological confirmation. I would always think in terms of establishing at least a clinical diagnosis before I go in with empiric treatment. So that's the same goes for empiric ATT as well. Place for procalcitonin.
Well, are you ready to show the case? Okay, some issues with
Yes, sir. Already.
Go ahead. What about the procalcitonin making a diagnosis of etiology of FUO?
There is no place. I think that's a very short answer. Procalcitonin is a biomarker which is prognostic for sepsis. So there is no place for determining the etiology.
Okay. So when you will do PET-CT in your practice, what time you want to do the PET-CT? Is there any specific criteria used to do PET-CT? Even though the cost has come down, but PET-CT is widely available. So at what stage of your PU or do you think PET-CT is an idea?
So, I mean, there are two ways to do a PET-CT. Generally, I would do it once my initial tests are negative. But PET-CT as a first-line option is probably not something I would consider. Though if you look at most of the series of FUO abroad, PET scan is actually the first thing that they do. But in India, the cost prohibits a PET scan from being something that you would do upfront. So in my practice, I don't use PET-CT upfront. I would use it probably after I find that there is nothing going on, and I tell the patient, okay, you need to come back in 4 weeks' time. And when they do come back, at that point in time,
Sir, ready, sir. Already shared la da, sir. Okay. No, sir. Already shared.
Moving slides. Some issue with Dr. Pogarwan there.
I can hear you, sir. Shall I start presenting?
Yes, sir. See,
Hello.
yeah, you can proceed. I think he said you can proceed.
Yes, sir. As a short case, I will go through fast with the history. A 46-year-old man from Assam, native of Assam, working with daily wages, came with a fever and headache for 1 month, followed by slurring of speech and weakness of left upper limb and lower limb for duration of 20 days. So fever was on and off with chills, night sweats, no night sweats, headache after fever episode, generalized, disturbing his daily activities, no vision disturbance, followed by slurring of speech and weakness. No head injury, other system involvement, no significant weight loss. Past history, no comorbidities, not on any chronic therapy or chronic drugs, medications, no contact with TB, past history of TB. Before getting consult here, he had visited elsewhere at his native, started on empirical ATT, and discharged after 1 week of stay. After 4 days of discharge, his headache got worsened with weakness of left upper and lower limb, and readmitted again. Evaluation revealed the hepatitis suspected as ATT induced and modified. So, what are the differentials and approach at this point? Shall I proceed, sir, or shall I wait for response?
Proceed, because we left
Yes,
time.
okay, sir. Yeah. So the investigation revealed total count with normal neutrophils and other cell lineage.
Good evening, Suresh. Dr. Palniappan. Hello,
And
Suresh.
Good evening, sir. Sir,
Yes, Suresh. I am in the line. Okay. You can proceed. Yeah,
Yes,
no.
an examination, there is no cervical lymphadenopathy vital stable except for the focal deficit on the left side. Other investigations, there was a derangement of liver function, including AST, ALT, alkaline phosphatase is normal, HIV status turned negative, and this is brain imaging.
And
so it reported as the multiple lesions.
At this point of time, please, participants can vote. What do you think? Because the speaker told clearly, according to our practice, first PUO cause, according to her, extrapulmonary TB. Already TB medicine started, but still the patient is not improving. Do you think TB is a cause for it? Still, the empirical TB trial is good. Just vote on. Okay, we'll carry on. People start replying. Go ahead, Pugal. Pugal, proceed. Can you hear me? I think some issue with Dr. Pugal there. Okay, so the bottom line of presenting this case is TB is quite common, particularly extrapulmonary TB is common, we agree, but still if the diagnosis is not made, if you think TB, most of the time we miss some differential diagnosis. Fortunately, this patient's willing for it. We did a biopsy of these lesions and it turned to be milioidosis. Some of the participants already answered, so it turned to be milioidosis. So we need to know, don't think TB unless we did reasonable workup and we excluded all other causes, then we finally think about empirical ATD trial. Here the patient has not completed all the investigations part. Unfortunately, was willing also. The lesion is also accessible. So we did the biopsy. It turned to be milioidosis there. So we are in last couple of minutes. Almost 8:30 is over. Any other questions people want to ask to the speakers? Sir, Dr. Paniappan sir is a former secretary of Tamil Nadu APA as well as current academic coordinator. Any words of wisdom, sir?
Yeah, today topic is very interesting. Actually, I joined just now only. So a lot of PUOs in detail, my dear friend Dr. Suresh Kumar has discussed in detail, I think. Because FUO, nowadays we need not call it as a FUO because many times, almost with all the available investigation, we can come to a conclusion within a day max. And clinical, usually FUO diagnosis, history, that is serious, that's consistent daily history taking is very important. Clinical examination is very important. Any findings as well as investigation, serial investigation, serial history taking, serial clinical examination. Always you have to do the neck stiffness. Many patients we will be missing yearly tuberculosis meningitis and malaria also, and common things are urosepsis also we are missing many times. And any scrub types always, sometimes you may not find out any score. Still you have to suspect by various presentations as already Dr. Suresh would have been discussed, I think. Scrub may not be there. And lot of PUOs, commonly urosepsis, tuberculosis, extrapulmonary tuberculosis, scrub types, and malaria also, many times it's missed. And common things are always common, rare things are always rare. You should know rarer manifestation of common disease. The I will pass on to the audience. It's very important to diagnose, and highlights of suspicion is very important. And history taking and travel history, type of food, what type of where they have traveled, and whether they took bath in some area, pots and other things, leptospirosis, many things you should not forget to ask all the detailed history, very important. And duration of illness, whether less than 7 days duration, fever or 24 days, depends upon get an idea. We can confirm with various investigation what is that is antigen. Detecting the antigen is very important, but it's also equally important. Okay, they got a lot of wisdom from my dear friend Suresh's detailed discussion, more than 1.5 hours. Thank you very much, Suresh.
Thank you, sir. Thanks for your final summary and conclusions part. Support. You did my job very well, sir. Thanks for providing support. I sincerely thank Dr. Priscilla Rupali, despite her busy schedule, joining and put beautiful presentations today and provided beautiful teaching cases to the PGs also. A lot of interesting stuff she provided today. How to diagnose lepra reactions and very interesting stuff. Usually gram-negative endocarditis is a bit rare, but she provided gram-negative native wall endocarditis. A lot of interesting stuff she provided to the participants and answered almost all the questions raised today. And Pogal for joining. Unfortunately, some issues with the presentations today, but thanks Dr. Pogal also presenting this case today. And I sincerely thank APA and ICP for providing this wonderful opportunity. And usually for the participants, this is not the one session. This is a 6-month course going on every week, Saturday between 7:30 and 8:30 p.m. Already people join, those who want to join, also a lot of room to join. So we are providing not only one PPT or one couple of cases discussions. This is a 6 months long program. Anytime you can put a lot of teaching programs if you want to learn any questions you want to ask the either faculty or to the course director. We are happy to provide more help. And this type of new materials, for example, this is a BMJ publications happened last week. If you want to gain access this type of presentations, you need to join the 100-degree group or some of the protocols, what the new BMJ publications happening. This type of things can be available to you. And we are bringing up a good newsletter shortly there. So those who want to know more ID update, you can get the ID update by joining this WhatsApp group. And finally, I conclude with Dr. Priscilla Rupali, thanking her for busy schedule joining, and she's not well today also. Despite the things she joined today, sincere thanks from AP and ICP as well as from the post director. I thank Dr. Praniyappan sir, despite his busy schedule, joining it at the whatever time is available, sir is joining and providing his insights, particularly from the secondary care level hospitals. We are providing tertiary care hospitals level input. He's providing inputs from the secondary level, and all the participants who joined. And despite some technical issues today we face, in future we'll sort out these issues and do good presentations. We are happy to take more questions subsequent to the presentations also. Thank you one and all.
And before concluding, Suresh, I want to ask one question. That's just a 10 seconds question. Erythema nodosum is the commonest cause etiology streptococcal infection. I am having a patient with erythema nodosum, type 2 diabetes mellitus, hypertension, dyslipidemia on treatment, and the patient is having eczema over the foot and leg. After completing the antibiotic course, still erythema nodosum not subsided. I gave steroid, better with the steroid, it is subsiding like anything. Multiple nodular swellings with erythema surrounding. What could be the cause? I have ruled out lepra reaction, leprosy, everything.
I think like our speaker is still there for even though the time is exceeded. Dr. Priscilla, can you throw some light on it?
So erythema nodosum, like you rightly said, has a variety of differential diagnosis. And one of the other differentials, you rightly said, streptococcal disease can actually be one of the causes. It can also be erythema nodosum leprosum. But one thing that you can find is TB. So TB in the initial stages, when you have the primary infection, can actually present with pleural effusion and erythema nodosum. So it's important to do actually a skin biopsy and see if there are granulomas there. And this is one person where you would do your cultures, your expert and everything. And, erythema induratum or Bazin, that's a very common differential for erythema nodosum. So the patient may benefit with an empirical trial of ATT.
Oh, no constitutional symptoms. Still, you're suggesting to take a biopsy, skin biopsy, with nodosa. Okay. Any other points, Dr. Suresh? Hello? Hello? Any other points you want to add, Suresh? Hello? Am I audible?
You're audible, but I think Dr. Suresh has...
Okay.
left.
He has left, I think. Okay. So you want to do biopsy, skin biopsy from the nodosa. Okay.
Yeah.
Okay. Thank you so much. Thank you.
Okay. Thank you very much.
Yeah. Thank you very much for everyone. Thank you.